Our next speaker is Martin Knapp. He's a university-based researcher from the London School of Economics and Political Science at King's College. In addition to being a major Siegel supporter, he'll be discussing how economics factors into optimal mental health services and how these services are affected by the environment they exist in. Ladies and gentlemen, Martin Knapp.
Thank you very much. I realized when I came in this morning, it's the second time I've been on this stage now. I'm hoping not to be as nervous as I was the first time, and I'm hoping not to repeat the performance the first time, because the first time was nearly 50 years ago when I was a male chimpanzee in the musical Noise Flute. I can't remember where it was. I probably wet myself, but it was somewhere around here, I think. So I hope not to repeat that today. So what I want to talk about, after that, everything will be disappointment. So what I want to talk about is economics. I'm an economist. I work very much in the mental health area, primarily the mental health area. The title I've put up here, just to remind myself of my structure, is slightly different from the program, but it's covering the same territory. I want to talk about challenges that we face, particularly economic challenges. I want to talk about the questions that economists get to be addressing, and then offering some answers. But this is a space, the youth mental health area is a field where there is very little in the way of evidence, particularly from an economics point of view. So let me just quickly zip through this set of issues and provide you with some evidence towards the end. So firstly, the challenges. You're going to see two slides with that big font. That's the two difficult words of the day, if you like. One is scarcity. I'll show you the other one in a moment. The problem we face is every society has a problem of scarcity. There is never enough to meet all our needs. There are never enough resources to meet all the needs of individuals or their preferences. And so we as a society have to choose. We have to find a way to allocate those resources, or to ration them. I put the word up there, though politicians don't ever use that word. But to ration those resources between competing needs. And so that makes it very tough for decision makers who are there with a budget to allocate between different competing demands. But there's also a second challenge, I think, that's come up in many countries in the last few years, and that's this global economic recession. And so the other big font word in the presentation is recession. I do want to emphasize, however, that economics and economics evidence in this area is not needed just because we're in a recession. We need it all the time. We always need to have evidence to help us in the allocation of resources. But at times of economic recession, it makes it particularly tough because many public budgets are shrinking. Many individuals are finding it very difficult to get a job, to stay in a job, to have enough income to support their needs, and so on. So there are lots and lots of challenges, which, as we've heard about already today, will lead to growing demands for various services. And I'm going to go on to that now, just to pick up something here about the consequences of recession. Recession is bad for your mental health. Now, in that blue box, what I put in there is just some of the correlates, shall we say, of a recession. These are the things that economists would use to tell us we've got a recession, if you like. Things like high levels of unemployment, greater frequency, greater levels of poverty, lower salaries for people that are lucky enough to be in work, reduced household and personal income, more personal debt, particularly debt that people don't feel they're in control of, and mortgage failures and other such indicators. Now, what I'm going to show you now on the slide are the consequences of those aspects of economic recession for people's health and particularly mental health. And each of those yellow boxes contains a consequence which is evidence-based. There's evidence showing the connection between something in the blue box and those yellow boxes. I'm not going to go right through them. I'm going to show you just three examples of some of the challenges we face. So the first one, this is a study, goes back now 9 years, published 9 years ago, so conducted earlier than that in Finland. It looked at just over 500 triads of mother, father, and 12-year-old child, and looked at the consequences of the economic recession that Finland went through earlier than the current global recession we're experiencing. And they were particularly interested in the links between poverty, unemployment, and common mental disorders. And what I put up here, lots of words, I apologise for that. What I put on the slide are their main results. What they found was that the reduction in the family income, money that was available to them, particularly difficult during the recession, that reduction was associated with a higher risk of youth mental health problems. So there was a greater prevalence of those problems developing, both emotional and behavioural problems, because of the economic pressure. And that was even after taking account of the fact that the young people may have had some history of some mental health needs prior to the study starting. There was also a connection across from the young person's mental health before the recession to the parents' health during the recession. Now, this is a very complicated study and there's a complex set of connections there. The point is that recession wasn't good. It wasn't affecting directly, shall we say, the children, but it was certainly affecting them in a very major way. Here's a second one. This is a study published, there's two things on this slide. This is a study published 6 years ago in Health Economics, looked at a big longitudinal cohort data set in the States, the National Longitudinal Survey of Youth, and looked at the waves of data collected over a 7-year period. And what the researcher found then was when the economy got into worse difficulty, there was greater teenage use of marijuana and hard drugs, and probably greater use of alcohol, though it's a less strong relationship. There was also greater tendency for teenagers to be selling drugs. So recession, again, having very unwanted consequences. The other study I put at the bottom there, the Pakula study, it's a review. And it's got one of my favourite results up there. What happens to drinkers during a recession? I usually ask my students, and they always usually get it wrong, actually. Heavy drinkers drink less and light drinkers drink more. So you can work out when you're in the bar tonight which one you're in and which direction you're going in. But it does vary by type of economy. I can go into that in more detail if you want to. The third example is, again, there's not much good news in this presentation, I'm afraid. The third example is about the consequences of recession and linked to employment patterns and stigma. And I was involved with a study which looked at data across all 27 EU countries. And what we did was look at patterns of employment in 2 years, 2006 and 2010. And what those two lines on the graph on the slide show you, the blue line, the bottom one, is the people without mental health problems. And it shows you percentage unemployed. And my glasses will just about help me. It's about 7% in 2006. Percentage unemployed goes up to about 9% in 2010. But for people with mental health problems, this is self-reported mental health problems. These are people with common mental disorders. Firstly, the unemployment rate is higher in 2006, and it grows much faster by 2010. So what you've got is a number of things we know, that people with mental health problems have greater difficulty getting a job or staying in a job or finding a decent job. But it seems that during a recession, the difficulties get even worse. What we then did in this study was to look at evidence across those 27 countries about the level of stigma about mental health problems. And I put the result on here. And the disadvantage that people with mental health needs experienced was greater in countries which have more stigmatizing attitudes towards mental health. And I would say, as I put at the bottom of the slide there, that's likely to have particular resonance, particular implications, I think, for young people. So, at the end of this very cheerful little section of the presentation, recession is bad for you. It's particularly bad if you have a mental health need. It's particularly bad in places where attitudes to mental illness are very negative. And I'm not going to go through the detail on this slide, just to emphasize we know there are causal links in the other direction. So people with mental health problems are at greater risk of economic hardship. And I won't go through there. I will put at the final slide my email address, and I'm very happy to make slides available if you want to contact me. So what about the questions? Economists get asked to address a number of questions. And I'm going to put the 4 most commonly asked questions to me, if you like, or the economists get addressed. Firstly, what does it cost? Secondly, can we save money? Thirdly, is it worth it? I'm going to come back to that one in a moment. And how do we make it happen? And those questions correspond to studies that economists carry out. And I'm going to show you just 2 or 3 studies with bits of evidence which are relevant to the conference here to try to illustrate what we know about some of the economic consequences and some of the economic payoffs that might follow from doing good things in terms of service delivery. So firstly, I put answers with a question mark because, as I said at the beginning, there aren't very many studies in the youth mental health area that look at the economic issues. Now, one slide, lots and lots of things on it. On the left-hand side, you can see what I put some of the causes, shall we say, of, I call them long-term needs. What I've put in the yellow boxes are some of the consequences of those. And that's what I'm mainly focused upon. So somebody with an enduring mental health problem, for example, is likely to need help in many domains, many dimensions of their life. They will need healthcare, of course. We would hope they'd be able to get it, although as Chris was indicating, many, many people with mental health needs never get services that they need. Those people might also need some help with social care, from housing services, in education settings. They might be in contact with criminal justice agencies, and so on down the slide. So there are many, many elements, many, many dimensions of somebody's life that might be affected by them having a long-term mental health need. And what I'm going to add to the slide on the right-hand side, and this will, the acronyms will be only interpretable by people in England, and I apologise to the rest of you. It doesn't actually matter, except that they are different. And the point I'm trying to make is that those services are delivered by different parts of society. And those different parts of society have their own budgets, and they have their own performance indicators, and their own constraints, and their own decision-making mechanisms, and so on. And sometimes it's quite difficult for those different bits of society to get together and to coordinate their actions in the best way that's going to be helping the needs to be met for the individuals concerned. So that's the challenge we face, that people with mental health needs often have needs across many, many, many domains. And I'll illustrate that with just one quick study. It's a study that I was involved with a long time ago now. It's been published 12 years or more now. And this was a study followed up a group of people that Michael Rutter had studied in 1970 in one borough of London. And what he had done when these people reached ages 27, 28 was go back to them and get some further information. And I'm going to show you information for 3 groups of 10-year-olds when they reached age 28. Now, the 3 groups are in the red on the slide there. There's no problems at school. These are children at age 10, no problems at school, no clinical diagnosis. Secondly, there's a group of children with antisocial behaviour at school only. And I put that meaning they didn't reach a threshold for conduct disorder. The third group is those with conduct disorder. And the 2 other groups in grey, I'm not going to talk about children with some emotional problems. Now, what we did was look at what happened to those young people between 10 and 28, those ages, and just costed up all the services they used. And I'll show you on this next slide what we found. So for the group at age 10 with no antisocial, no behavioural problems at age 10. These were the services they used, the additional services. So you can just about see it on the slide. The green at the bottom is education, the next one up is health, next one up is social care. The one at the top in purple is criminal justice. So these are young people, age 10, no behavioural problems reported by them, by their teacher, by the information coming through the study. The second group are those that were a real pain at school, actually, but didn't reach the threshold for a clinical diagnosis. And by the way, this is not a treated group of people across the whole study, it's just a routine population survey. So you can see the costs are higher. And then for those that had, by the criteria at the time, a diagnosable, although not necessarily diagnosed, conduct disorder, you can see the costs are hugely higher by the time they reach 28. And the big impact is in the criminal justice area. That's the big cost component in that column. So what we've got is a problem, shall we say, a need, a behavioural need, which is primarily the concern at age 10 of the health system, but the payoff to the health system doing something about it is going to be tiny. The payoff to the rest of society will be enormous. And that's one of the challenges we have of coordinating services and responses in this area. And the second study I'll show you is another longitudinal study. It's a much bigger sample. This is one of these big birth cohorts, looks at everybody born in the UK in 1 week in April 1970. And what we did was look at data on these people at age 10 and age 30. And at age 10, what we did was look at the characteristics, and we identified, if you like, a degree of need, a degree of problem in the mental health domain. Identified those with anxiety problems, with antisocial conduct, and with attention deficit. And then we looked at what happened to them at age 30. Now, some of these people would have dropped out of the study, particularly those with very severe problems, so you've got a bit of a bias. But this is the summary slide of what happened, and I need to explain this. So you've got the 3 columns, antisocial conduct, attention deficit, anxiety. Those are the 3 groups of people at age 10. On the left-hand side, you've got for males and females separately the 4 economic indicators we looked at. Firstly, are they economically active? Basically, are they in a job? Secondly, what level of job, occupational attainment, occupational status. Thirdly, what earnings they had if they're in employment. And then fourthly, their expected earnings. So that's taking account of the fact that people who are not in a job would have very low earnings, and we've averaged those across. Now, generally speaking, you've got the word worse or you've got a dash. Dash means there was no relationship between that characteristic of mental health at age 10 and those economic indicators at age 30. Worse, it means that those young people with those characteristics at age 10 did worse than the rest of the population at age 30. So look at the females in the attention deficit group and the anxiety group. Girls at age 10 with those 2 problems, one of those problems, had much worse outcomes at age 30 in those various areas. What you've got is a slightly anomalous finding, perhaps, which is that antisocial boys at age 10 did very well, thank you, at age 30 in terms of earnings. They were less likely to be in a job, but if they were in a job, they did very well. Now, I've presented these results many times, and I usually ask people to shout out what jobs you think those people might be in. It always used to be building sites, but the last 2 or 3 years it's been bankers, but you can choose, okay? But there are certain occupations where actually having those characteristics of aggression and confidence and various other characteristics might well be a plus factor. There is research which shows that benefit does not persist into the 40s. It just happens to be in early adulthood. Okay, I've got a yellow line, so I need a quick yellow light to come up. Let me just quickly talk about cost effectiveness. Cost effectiveness is what it says. It's a blending of cost and effectiveness. It is not just looking at cost. It is the blending of the cost picture and the effectiveness picture. And the challenge, and I need to finish this slide and then I will stop. The challenge in this area is how do we get that 2 bits of information together? The information on what it costs and what outcomes are achieved. And what I really have to emphasize, particularly in the youth mental health area, is that for something to be economically attractive, it doesn't have to be cheap. It doesn't have to lead to savings. Because many things are economically attractive, even if they cost more than what we were previously doing. But they become economically attractive because the value of what we achieve by changing our practice is worth it. And that's the key issue we have to get decision makers to think about. They may sometimes have to put more money into a service, but the consequence could be considerable. The positive consequence could be considerable, and that should make it worth it. And I will stop at that point. Thank you very much. Okay.